Thank you very much for the introduction, and Lisa and Erica, thanks for inviting me. I'm going to share my screen here. Can everyone see that?
Yes, we can see your screen.
Good.
Looks great.
Starting on slide 9 here. All right, slide 1. Good. All right. It's my pleasure to talk to you all today. Thanks a lot for inviting me. We're going to talk about surgical strategies for pediatric epilepsy. It's early in the morning, so I get the first talk, and that's nice. Everyone must be fresh. The disclosures, I actually recently gave an educational talk for Medtronic. I guess they own me now, but I have to disclose that, but that shouldn't have any relevance to this talk. I always start with acknowledgements because there's never time in the end, but specifically Haley and Sarah, who helped me get together some slides and for this talk. I want to thank them specifically, and Michael and Eugene, just awesome technicians who actually were with me till a little after midnight last night doing a case here at Riley. So thanks for all you guys do. We're going to talk about medically refractory epilepsy briefly, therapeutic strategies, and then a very complicated case. So as all of you guys know, epilepsy is a seizure disorder, right? And a seizure is a hypersynchrony of neuronal discharge, which means that all of a group of neurons fire together, which is abnormal. The International League Against Epilepsy is just this governing body made up of neurosurgeons and epileptologists define the treatment goals for epilepsy as no seizures and no side effects. And that's a very broad goal to achieve. But that really is what we're after. Any medically refractory patients need to be evaluated by a comprehensive epilepsy program. And we know that about 30% of patients remain medically refractory with medications alone, and that 30% of patients is the target group for seizure surgery. Ongoing seizures, of course, profoundly affect the developing brain, especially in children, and medications as well affect the neuronal plasticity. From a underlying philosophy of epilepsy, there's basically, it's our understanding that there's basically an area of the brain that is causing seizures, that is dysfunctional in some way, either because of increased glutamate transmission or decreased GABAergic transmission. There's something that is leading to excessive neuronal synchronization, which causes seizures and causes epilepsy. And that seizure onset zone can be alone, or it can be multiple different seizure onset zones that then have aberrant connectivity, and then those fibers that wire together is the Hebbian postulate, and so it gets stronger and stronger over time. So it's really important to identify these medically refractory patients early and then have them go through a medical workup. And that medical workup is a phased evaluation, 1 through 4. Phase 1 is the non-invasive, actually, evaluation that's recommended for all medically refractory epilepsy patients, and it includes video EEG, which y'all do real well, and a history and physical, a structural imaging of some kind, and then functional imaging, which has many different modalities, including functional MRI, resting state functional MRI, spectroscopy, DTI, et cetera, et cetera, et cetera. And then if everything makes sense on a phase 1 workup, then you would move on to a surgery of some kind, most likely resective. So in this very simplistic case, patient has sort of right frontal onset, all the data is concordant, we would remove this right frontal lesion per se, and patient would be cured. And there are multiple different strategies overall to treat medically refractory epilepsy, including resective surgery, disconnective surgery, which probably has the longest history in neurosurgical applications to epilepsy, neuromodulation, and ablative surgery, which is sort of new age, minimally invasive, or at least minimal access surgery. But in kids, unfortunately, they have a lot more frequent extratemporal seizures versus adults, which mostly is temporal lobe seizures. And they also have more multifocal seizures. So like kids with tuberous sclerosis, for example, have many different tubers, all can cause epilepsy or be involved with the seizure network. And so it's much more common in kids not to have a straightforward epilepsy syndrome. And in those cases, when all the data is discordant or the patients are just too complicated from the outside, from a scalp EEG, we do intracranial EEG, and that comes in two major flavors, which is subdural grids and strips, which you see on the left x-ray of the head, which is where we actually put grids on the brain and record from that area, and then plan a surgery based on where the seizures come from, which electrodes come from. We literally can almost draw a line between electrodes like 45 and 46, for example, say cut out 45, leave 46. Versus stereo EEG, which are the other three, and you see these percutaneous placement of bolts and then electrodes going into the bolts. And at the end of the talk, I'm going to have some examples of what those recordings actually look like. So that's basically medically refractory epilepsy. There's a huge number of these patients, huge. And you would think since 2001, when it was published by Quan and Brody, that these are patients who are significantly at risk and need to be evaluated by a comprehensive epilepsy program, that we would just be overwhelmed by a population of patients being investigated, but that's not actually the case. And it's multifactorial, but probably because families tend not to want to have brain surgery electively. Also, I think there's misinformation among neurologists and referring physicians about how dangerous modern neurosurgery is. It really isn't that risky. The side effect profile is very low, and the technology has really vastly improved since 2001. So that being said, let's talk about a few things. Resective surgery is maybe the oldest surgery. I mean, it didn't take long for people, once they started identifying that there's localization of function within the brain and that those dysfunctional areas can be cut out and removed and patients do better, for people to start doing lesionectomies, lobectomies, etc. So this is a brief case of a patient who's left-handed with left mesial temporal sclerosis. Age of onset, 1 to 4 years of age, unsure, sort of, there were some febrile seizures, then unprovoked seizures at 7, but you'll see that this patient wasn't treated until age 14. So therein lies this problem that I'm gonna harp on forever until we start increasing the number of patients get a phase 1 workup and ultimately successful seizure surgery. But anyways, the seizure description was sort of confusion, grunting, no clear aura, sort of temporal lobe semiology. Birth history, really nondescript, born at 34 weeks. This is an example of our complete workup here that the neurologists actually present. So it's very comprehensive. It includes which are the current anti-epileptics, which are the past anti-epileptics, and why they failed, including loss of efficacy or cognitive slowing or emotional outbursts, et cetera, et cetera. This particular patient's never had a ketogenic or modified Atkins diet or vagus nerve stimulation with a normal physical exam, although they do struggle in school, and that's normal for these kids who are on multiple medications and have refractory epilepsy. Seizure onset looks to be about F7 and T3, so frontal temporal on the left, and then a PET scan shows hypometabolism of the left temporal lobe, and then word generation task shows really no activation of the left temporal lobe, as does auditory description tasks and the functional MRI. So this would be a summary slide that was presented for this patient, basically localization of the temporal lobe down on every level from semiology, interictal and ictal EEG, MRI, and PET. So structural, functional, video EEG, all localizes to the left, all localizes to the temporal lobe and lateralizes to the left temporal lobe. So this is like a slam dunk case, right? Everything is concordant. This patient's indicated for a temporal lobectomy with amygdala hippocampectomy, and we do intraop ECOG to make sure that we go back far enough, but not too far to cause any overall loss of eloquent cortex or loss of speech and so on. And so here's an example of what that looks like post-operatively. You can see the white here is CSF. You can see the superior temporal gyrus still in continuity with the white matter here, and the rest of the temporal lobe gone, including the mesial temporal structures that were bright white before, concordant with mesial temporal sclerosis. And the axial, you can see sort of the right temporal lobe looking pretty normal, and then an absence of the left temporal lobe down to the petrosal ridge, going back about 4.6 centimeters. So this is a very effective surgery, patient seizure free. Unfortunately, it took 10 years for them to get to a comprehensive epilepsy program. Now that's like sort of a resective, maximal sort of approach, right? Take out as much tissue as you need, but it's usually quite a bit. Now, that's been more or less, I wouldn't say replaced, but I'd say iterated upon. Over time, people have decided, well, what if we can just take the mesial temporal structures in some cases, and then laser ablation has come to the forefront in about 2007 when it was FDA approved. And I would say that we're past the peak of inflated expectations, and we're sort of here on the slope of enlightenment as to who benefits from this minimally invasive strategy that tries to change sweeping skin incisions and craniotomies of the past into bolt placement and lasers through it. And this is a very effective surgery. This happens to be a Monteris slide. We don't generally use Monteris here, but I did in fellowship. We use Visualace here. But basically, the Visualace catheter is 1.65 millimeters, very small. And it goes through a 3.2 millimeter burr hole. So often these patients can't even find the incisions on their head. And I'm not kidding about that. It's very low risk, low pain profile. And the hemorrhage risks appear to be similar to stereotactic biopsy. The thermoablation is very precise. We can use MRI guidance to protect structures we don't want to ablate and destroy the structures we do want to ablate. And I mean, just yesterday we did a brainstem, we did a ablation of a little residual ependymoma that was right attached to the brainstem. And so I put sort of low limit temperature markers on the brainstem, and then high limit ones in the tumor, and then sort of move the laser in and out to try to make sure we destroy the tumor but leave the brainstem alone. So basically, you put a laser into tissue, you turn it on in the MRI scanner, it emits light, light is absorbed, creating heat, the heat destroys the tissue. It's pretty straightforward. This has been applied to a lot of different seizure etiologies, but most commonly it's reported for selective amygdalohippocampotomy, and it has replaced, in some cases where patients have mesial temporal sclerosis, most effectively, a full temporal lobectomy. So you can see there was an approach back here, there's an artifact, the laser goes in along the mesial temporal structures, and you turn it on, you destroy the mesial temporal structures, but you leave the rest of the temporal lobe alone. You might do this in a patient who has a dominant left-sided language hemisphere, but seizures coming from that side. So you might elect this strategy, for example. Again, this is not new researchy. This has sort of been used since 2007 and even before in order to get FDA approval. This is a manuscript I put together with Dr. Curry, who was the first person to apply this technology to a patient with epilepsy. And it shows about a 67%, if you look at over the course of all studies, 67% efficacy at 1 year if the patient has mesial temporal sclerosis. And if the patient doesn't have mesial temporal sclerosis, then it drops down to 44%. And if they have no MRI lesion at all, it's just guessing, it's 20%. So probably not an effective strategy for those patients. Just to sort of further explore this technology. I mean, this is a really cool technology. You can see this is a 23-month-old patient with gelastic seizures, this laughing, this mirthless laughter. They just go, and there's no character behind it. You can see this laser coming in from the left into the hypothalamic hamartoma, and then you can see these post-operative T1 post-gadolinium scans where you see breakdown of the blood-brain barrier caused by the thermal injury. And you can see, like, I would have protected the brainstem here, I would have protected the thalamus here, protected the contralateral hypothalamus here. This patient left on post-op day 2 seizure-free and has stayed seizure-free. And this is what it looks like in real life. I mean, this is a tiny child, right? And so we have these fixation posts into the skull, but not too far into the skull. And then you have this localizer. And so this is a whole to-do. This is like a big deal surgery, but we're using a minimally invasive strategy. And this has far replaced, making a big incision in the skin, opening the bone and dissecting all the way down through, this is how they used to do it, through the corpus callosum, through the ventricle, through this ventricle, and then you just look at it, right, from 10 centimeters away and try not to destroy stuff that you don't want to destroy. So this is clearly a better strategy with more effective results, to be honest. This is a patient that we did an ablation of a tumor which was in the insula, and this was causing medically refractory epilepsy. And I pitched laser ablation to this family, and they didn't want it. They wanted me to do a big craniotomy and go through the Sylvian fissure, which is extremely dangerous. But I did it, and I got the tumor out, but it immediately regrew. You can see it there. And so because it immediately regrew and the patient still had seizures, I convinced them to do laser ablation. And that's what you can see here. So you see the thermography going on as I turn the laser on, and then you can see the deposition of a pigment called the thermal damage estimate. And as the temperature stays hot for a length of time, an equation called the Arrhenius equation defines the predicted kill zone. And then you can get images afterwards. This will show you the blood-brain barrier breakdown around it. It's completely encases the tumor. You can see it kind of gets very close to the putamen, which was acceptable in this particular case. And at 1 year follow-up, you can see it's just a little tiny scar. That patient's seizure-free. We did publish that, which was interesting. So disconnective surgery, this is maybe, besides resective surgery, the longest history that we have as surgeons with epilepsy surgery. It includes corpus callosotomy, hemispherectomy, and hemispherotomy. And I've covered hemispherectomy and hemispherotomy, I think, with ISETT before. I'm not going to cover that again. The corpus callosotomy, that has two different approaches now. The classic tried and true, which has been done since the 50s with good efficacy, creating split brain patients and ultimately leading to the Nobel Prize. But it involves sort of an interhemispheric approach where you have to come down through the interhemispheric cistern here, and then you retract on one side of the brain or the other, and then you cut this corpus callosum using a microscope. And that's effective, but there are risks, of course. You're retracting on the sagittal sinus, and they have risks of hydrocephalus and bleeding and stroke and so on and so forth. And their stays are not usually 1 or 2 days, usually like 4 or 5, 6 days in the hospital to recover from that sort of craniotomy. So it's not without risk. Now, in January of 2018, this paper was published, which describes using lasers, and you can see the approximate shape of the corpus callosum, at least in this case, is amenable to sort of 2 or 3 laser placement. You can see this one coming through the body from the back, this one coming through the genu from the front, and here's another angle, axial angle of the laser going through the body to the front here. This one didn't go after the splenium. You can see here something has happened with this patient where there's just a residual little splenium, and they put a single laser into the splenium to destroy it. And they published good short-term results for drop attacks and atonic seizures and tonic seizures. And so we started adopting that shortly after 2018. And we've done 8 of these with pretty good results. And this is how we do it. We put bone fiducials in the scalp, and then we get an O-arm spin. We register or merge that O-arm spin with our preoperative plan, which is usually on an MRI scan. And then we place the child in 3-point fixation, immobilize the head. This is the ROSA stereotactic robot, and we show it where all these bone fiducials are. Because the robot now knows where the bone fiducials are and the computer has matched the preoperative MRI scan with the O-arm scan, the ROSA stereotactic robot, which is the only one in the state currently, knows now where all the trajectories are and knows where all the stereotactic points in the child's head are. And so we can then achieve stereotaxy by just hooking up the robot to the patient's head underneath these drapes. It's actually literally attached to the Mayfield. And then we use the robot to go to a trajectory, and then we drill through that ROSA stage. Then we place the lasers through the bolts, and that's how you do it. And in the end, you have sort of, for corpus callosotomy, I've always done just 3 lasers. So you have 1, 2, 3 lasers in the corpus callosum, and then you transport down to the MRI scanner. And, we get pictures just exactly like that publication. This is my old fellow scrolling back and forth between the thermography overlay and the background where the Arrhenius equation predicts your kill zone. Really though, modern epilepsy has sort of progressed to the era of neurostimulation. And that's not to say that epilepsy surgery hasn't used neurostimulation in the past. In fact, there's a full century or more of experience. It goes back thousands of years if you want to go back to when they first started applying electric fish to patients, but that's mostly quackery. They didn't know what they were doing. In the 18th century, of course, Galvani and Volta sort of started understanding what it means to use electricity, to store electricity. And it was until the 1960s where we started having deep brain stimulation for indications of pain, and from that came the gating theory at Melzack and Wall, which was applied to spinal cord stimulation in 1967. Then you see motor cortex stimulation in 91, vagus nerve stimulation, and then ultimately responsive neurostimulation. And I should also add on here 2018, deep brain stimulation for the purposes of epilepsy. And so we'll just run through these. Vagus nerve stimulation, of course, listed first, but it's a palliative procedure, okay? It is basically the application of a device, a generator, that's hooked up to some electrodes that are helical in nature and wrap around the vagus nerve, which can be found between the carotid artery and the jugular vein. It goes on the left side. And the vagus nerve stimulator was first FDA approved in 1997, and now there's many more iterations of this battery, which are longer life and can sense ictal tachycardia and can have magnetic stimulation and can sort of auto titrate at home. So this battery actually now is very complicated and sophisticated, but the overall technology hasn't really changed. It really requires stimulation of the afferent vagal network. And we'll talk about that a little bit. But basically, VNS patients overall can expect about 50% seizure reduction at 3 years or 4 years. It's recently been approved in children above age 5. And before that, it was age 12 and older. And the efficacy in children is comparable to that of adults. The surgical risks are also very low. Small chance of vocal cord irritation, of course, always a small chance of infection. Basically, it works by stimulating the afferent vagal network, hoping that there is some connectivity between the nuclei of the vagus nerve, which include these nuclei: solitary tract, trigeminal spinal tract, dorsal nucleus of 10, and nucleus ambiguous, and the cerebral hemispheres, and that in some way, hopefully, it modulates the activity of seizures. And we don't really know how that works, and there's really no predictive mechanism. But we do know that time to implant matters. For example, if you implant longer than 10 years, your seizure freedom is almost non-existent. If you implant less than 10 years of seizures, then you have over 48 months, you have about 8% seizure freedom. So that's patients who are medically refractory, who are not candidates for intracranial surgery, who are having a palliative surgery by vagus nerve stimulation. 8% of them will be seizure free, which is different, much different, and better by about 300% than patients who are just continually trialed on failed medication after failed medication. So even in medically refractory epilepsy patients who go through a phase 1 workup, who are not candidates for intracranial procedure, they're a candidate for this, and their chance of seizure freedom is 3 times higher than any other medicine. So that is something to remember. Predicting seizure responsiveness, we talked about. There's no predictive mechanism to understand who is going to respond to vagus nerve stimulation, and that's one of the limitations of putting a vagus nerve stimulator in. These are not cheap devices. They are prone to infection, although that's not high. It could happen. You have to have iterative surgeries to replace the battery when it runs out. And so having a clinical predictive model of who's going to respond would be really beneficial. And it turns out that this guy, George Ibrahim, buddy of mine, he's a neurosurgeon at Sick Kids in Toronto, Canada. Very smart dude. And he, has this multi-site registry of patients who are going to be implanted with vagus nerve stimulation. And before we implant them with vagus nerve stimulator, you get a series of functional images, which are a MEG, magnetoencephalography, functional resting state, functional MRI, and diffusion tensor imaging. And that's an attempt to understand how is the brainstem that you're stimulating with a vagus nerve stimulator connected to the cerebrum. And so he's very interested in connectomics, and these are 3 different manuscripts that I stole from him. So I just cited them as George Ibrahim Connectomics. If you look them up, the first 3 papers will have these figures. But basically, this is a cute little picture of how, you know, the vagus nerve stimulator stimulates nucleus tractus solitarius, and then goes up to lucus coeruleus, other brainstem nuclei, and then somehow those go around, right? We don't know. That's what we're trying to figure out. And so these are some blob and stick diagrams of magnetoencephalography data showing patients who respond well on the left and patients that don't respond well on the right. And you can see increased connectivity. So apparently increased connectivity by MEG may predict an improved response to vagus nerve stimulation. Also, he showed by functional MRI that increased thalamocortical activity might predict responsiveness to vagus nerve stimulation. So in these sort of retrospective studies where he was like, well, I don't know, let's just look at patients who did well with vagus nerve stimulation and what did their MEGs and what did their functional MRI look like. He was able to sort of individually with these modalities find some predictability. So now this is expanded to a multi-site registry trial that we're part of in Boston Children's and Seattle Children's, a few other places around the nation. So if you come to our clinic, our comprehensive epilepsy program, and we indicate you for a vagus nerve stimulator, we automatically try to enroll you in this, which doesn't cost you anything and just contributes to overall literature and knowledge. So basically, time to implant matters. You need to implant less than 10 years of epilepsy, which I think is crazy, right? I mean, who would want to have medically refractory epilepsy for even a minute? Overall, vagus nerve stimulators are widely used. They're implanted by neurosurgeons and ENT doctors, and they're indicated, FDA approved for children less than 5 who have any type of seizure basically that doesn't respond to medicines, and they're not a candidate for intracranial surgery. However, some of those patients respond better than others, and we're still working out who responds the best. The device costs anywhere from $25,000 to $30,000. So it does need to be approved by insurance and so on. Deep brain stimulation was just FDA approved for epilepsy in 2018. I won't spend a huge amount of time on this, but there's a long history of deep brain stimulation going back to 1960s, mostly for pain, and then of course for movement disorders as it replaced thalamotomy, and more recently application to epilepsy. I would say the successful application to epilepsy with the Sante trial, which didn't allow at first the FDA approval of deep brain stimulation for the ANT, anterior nucleus of the thalamus, but has subsequently been used by everyone in the world except the US in a successful manner for both pediatric patients and adult patients who seem to have sort of temporal lobe seizures that are difficult to localize for the anterior nucleus of the thalamus, and maybe frontal or parietal lobe seizures that are difficult to localize for the centromedian nucleus. But basically, I mean, this is when it's anatomical, it's pretty straightforward for a neurosurgeon. In order for deep brain stimulation to work, you have to have selected the right patient, you have to target the nucleus appropriately, and you have to program it appropriately. So for a surgeon to talk about the efficacy of DBS, I mean, if it's straightforward like anatomical targeting, I mean, my job is pretty simple. I put the tip of the electrode in the nucleus it needs to be in, and then someone smart, like an epileptologist, programs it effectively and helps indicate the correct patient. So my role is to make sure that these are accurate, and that's what I do every day, and you can do it a lot of different ways. These are actually electrodes placed in GPI for a patient with dystonia that we did here, and we're starting to increase the volume of those patients that we implant. We still haven't done one for epilepsy, but we're ready, willing, and able to do so. We just have to indicate the right patient. DBS also right on par with VNS, 29 to 34,000. can have very effective seizure freedom rates, or at least responder rates, with about 76% in the Santé trial. There were some issues with depression and suicidality in that trial, which probably prevented it from being widely accepted. But in the epilepsy patients, I mean, I think that the data from Europe and from South America is quite robust. And over time, we're probably going to be using that quite a bit more, maybe even more than vagus nerve stimulation. And then responsive neurostimulator, I mean, this is the coolest, newest technology that exists. Everything that we've talked about previously is essentially an open loop system, meaning that it just tonically stimulates a square wave. Whereas the neuropace or responsive neurostimulation is responsive, right? It's like a brain pacemaker. So it can recognize the electrographic correlate of someone's seizure. And you can see up here in the top left, there's a snapshot of an ECOG stored by this device. And so it senses the electrographic correlate of this patient's seizure, and then it stimulates 3 times. And then, you know, the seizure abates and the electrical brainwaves go back to normal. And this is so cool because it actually can sense and then stimulate instead of just tonically stimulating. It means its battery life goes longer. It means it's a much smarter device. It does have some limitations as far as how many electrodes you can put in. You can only currently put in 2 electrodes, and until recently, it wasn't MRI compatible. So it wasn't even MR conditional, it was MR safe, but now it's MR conditional. So now we can put these in patients, you know, highly selected patients who have seizure onset, which overlaps eloquence. And that's really the genius of this device, is that it doesn't disrupt really the normal cytoarchitecture of the brain. It just creates electrical stimulation field that disrupts seizure onset. And that's a great application over what used to have to be done in eloquent cortex that was generating seizures, which was, you know, subpial transections, which actually involved just taking a 15-blade scalpel and stabbing the brain every 5 millimeters. And then that causes deficits. And I mean, that's not a good procedure. So anyways, responsive neurostimulation was FDA approved in 2013. So more or less new, but still, you know, around 7 years. And actually, because it was FDA approved in 2013, the data comes from before that. So we actually have 9-year data that was presented at AES, American Epilepsy Society, last December. And it shows what we usually see with neuromodulation, which is this increasing trend of effectiveness over time, and then it plateaus at some point. But the plateau for responsive neurostimulation at 9 years is upwards of 80% of patients. So of course, these are very highly selected patients. They have focal onset epilepsy. We know where it is usually by doing a stereo EEG or doing grids and strips case. So you've localized it. You know that their onset of epilepsy is in a smallish area and it overlies eloquence, and then you put this in. So these are highly selected patients, but they do really well. And the pivotal trial was done in 191 adults, no kids. It's not FDA approved in kids, but we can implant it in children, and we have here at Riley. So basically, you know, the stimulation group seizure frequency decreased 38%, and the sham group seizure frequency decreased 17%. That was a statistically significant difference. And then ultimately, when they opened the trial and did open label period, they saw a mean reduction of 44% at 1 year, 55% at 2 years, and like I said, at 9 years, 76%, I think, so almost 80%. Of course, anytime you cut the skin, you're gonna have complications. But this risk profile actually is pretty low for how effective this procedure is. This is a paper I published with my group at Oregon Health and Science University about how to implant it. This is one way of like a bunch of ways. But basically, this adult patient is prone. There's a planned incision on the right here that's going to involve placement of the device as well as one of the electrodes. This is a bitemporal placement. And then a small incision on the left where you're just going to put a depth electrode to target. And we use the Serotonin, which is an intraoperative CT scanner. But here we have the O-arm, and we use the O-arm here. This is the stereotaxy we chose to use at the time, which is called NextFrame, which uses a patient tracker with these 4 reflective balls on it. and then incision, surgery, and then you put the device in. So you do have to remove a piece of bone in order to seat this in place. So that is one limitation. Of course, if this whole thing gets infected, then they have an area here that is open. But we do that all the time, patients with trauma, and it's fine. We replace it over time. So we would treat a patient for an infection, and then we would fix the bone or put the device back in the idealist sense. And this is what the stereotaxy looks like. These colored lines are different sections through the brain. So you can see we're tracing down the path of each electrode, the predicted path, and then the actual electrode is this white part, and the white part doesn't really deviate from the tract the whole way, and that gets surgeons really excited. It's like, look how accurate I can be. Yeah, so that's what that's about. So basically RNS is, really cool. FDA approved in kids over 18, but we can really put it in kids as young as probably 8, based on the size of their skulls and the chance of them, growing and then dislodging the electrode, or just their scalp being very thin and causing some wound breakdown issues. The other thing is you have to upload your data kind of, to the cloud every week. So like on Sunday, go to church, and then you just upload your data to the company, and then your epileptologist can gain access to it and see how many seizures you're having. And really cool, they can see like, how many seizures are you having? And then we started Topamax or something. And then how many seizures do you have after that? And you can see sort of either like it goes down, you're not having any seizures, how effective is Topamax? Oh my God, it's awesome. Or like it's not effective at all because you're still having the same number of seizures. So it'll allow you to titrate which medicines can be effective. And so that's a really cool application of it. It can be used in, and we're about to do this here in a patient where, they have sort of bitemporal onset seizures and no lesion. And so in that case, but they're infrequent. So if you do a stereo EEG, you might wait 3 weeks and never see a single seizure. So in that case, we know they're coming from the temporal lobes, and we'll put depth electrodes in and we'll send them home, and then we'll just, record. Maybe it's an effective treatment for them, or maybe over the course of 6 months, we see that they're having right-sided temporal seizures, and we'll come back and we'll do a right-sided temporal lobectomy. So it's a really cool system. It's like almost twice as much as any of the other systems. But so far I have not had a single problem indicating a pediatric patient, and getting it paid for. So those are all sort of the a priori. We have concordant data, we're gonna do a surgery. But sometimes that's not the case, as we alluded to. And in those patients where there's discordant data, you have to do intracranial electrode recording, or intracranial EEG. And we talked about grids and strips versus depth electrodes called stereo electroencephalography, or stereo EEG. And this is just a picture of my robot, which is awesome. So here you see what we might see with intracranial electrodes. Okay, these are from Haley, so shout out to Haley Hill for giving me these. But basically, this is a right frontal electrode, and this is a referential. This is a referential EEG. Okay, so you see in this particular electrode, it has 10 contacts. The first, 8 or 7 are in white matter, and the last 3 are in gray matter. And so you can see the difference in activity and the amplitude. So the amplitude's much smaller in the white matter and larger in the gray matter. And in this orbital frontal electrode, this is a grid, this is a strip. And so all the strip contacts show kind of gray matter activity, so a little bit higher amplitude activity than the white matter activity. And in this case, it's a depth electrode that goes down to the mesial temporal structures. So you can see mesial temporal structure activity and sort of gray mattery amplitude, and then white matter as it's coming out of the brain, right? So so that's kind of cool to see the difference between the 3. And this sort of re-demonstrates it. You see the difference between white matter here and gray matter. White matter in these electrodes in the supplementary motor area, and this gray matter. And then here's an example of what it looks like when the last contact is in the bolt. So here in the anterior middle temporal gyrus, the first 7 are in the brain, and the last one is not. And so that one will be removed. And here's another example. So that is pretty interesting for them to see intraoperatively. And you can see how many electrodes we can cram into the brain when we use depth electrodes or even grids. So my last like 5 or 10 minutes, what time is it? Yeah, so the last 5 or 10 minutes, I'll just talk about a very complicated case. Patient with septo-optic dysplasia and left closed lip schizencephaly. So these are migrational anomalies, which generally lead to medically refractory epilepsy. This is a left-handed patient. Age of onset 3 years of age, and I will treat him at age 20. So that's very sad. But he did have a period of seizure freedom from 8 to 15 years. And at 15 years of age, it recurred. He had 2 semiologies, a complex partial semiology and a focal with secondary generalization. And he does, as I mentioned, have septo-optic dysplasia, a left closed lip schizencephaly. He also had a few heterotopias and so on. Born by emergency C-section, but didn't stay in the NICU or anything, was relatively well his whole life, developed essentially normally. Neuropsych testing showed that maybe there was some mild discrepancies in his language and visuospatial development. Current anti-epileptics included clonazepam, Topamax, and Depakote, not uncommon for me to treat patients on 3, 4, 5 different anti-epileptics. Past anti-epileptics include, phenobarb, Keppra, Topamax, ethosuximide. So really well trialed on all the different medications. Had a vagus nerve stimulator placed in 2017. And I mean, in defense of that, program, he was evaluated by phase 1 evaluation, and it was decided that he was not an intracranial resective or a patient who was a candidate for intracranial study. But the vagus nerve didn't help him. So wouldn't it have been nice to have some connectomic, clinical predictive model to understand, is he going to respond to this $30,000 device or not? But he didn't. So anyways, his physical exam, he has, a few little minor issues. Exotropia of the left eye on primary gaze. He's a little slow to ambulate. He's got some brisk reflexes, but overall he's doing pretty well for having medically refractory epilepsy for 17 years. Wants to be a truck driver. EEG, I'm going to show you the summary here because there's a lot of data, but basically there's really not great even lateralization for him. It's mostly left side, but there were some right-sided seizures, and certainly interictal activity was bilateral. And so here's an example of just the left-sided sharp waves that are here, the interictal activity, and then ictal seizure. You can see some sort of generalized onset here, but T3 is going to become important. And then you can see these sort of migrational anomalies that we talked about, these little heterotopias. Septo-optic dysplasia means that the midline structures are not preserved. And then you can see the schizencephalic cleft on the left side, very complicated structure. There's a closed lip schizencephalic cleft. And from a surgical perspective, when you're looking at it and you're trying to reproduce what the MRI looks like in your brain, it can be very complicated to operate on. Diffuse hypometabolism in the mesial and lateral left cortices. You can see that here. Looks like a shark bite. There's not any bright tissue here. There's just a dull grayness. And so for him, he had a lot of crossed activities. So you can see right temporal blobs. This is a functional MRI showing word generation tasks. You see activity across the left temporal lobe, particularly here where his schizencephalic cleft is, which is a bummer. And then on the right side, auditory description task, he has activation of the right temporal lobe. So essentially, this is a crossed language functional MRI, which means that he's complicated and you can't just go in there and do stuff. And so basically, his summary slide is just discordant, right? Very complicated. Localization, the temporal, the frontotemporal, left parasylvian on MRI, PET scan is temporal, and then lateralization, mostly left, although there was a little bit of right activity, and then a bunch of anatomical abnormalities, polymicrogyria, heterotopias, schizocephalic cleft, with cross dominance language. So, I mean, this is about as complicated as it gets. Complicated patients need a complicated operation. So Big Mo was 20, and he had septoptic dysplasia and a left schizocephalic cleft. Seizure semiology, super complicated. Had a VNS which failed. Our plan was to do a phase 2 evaluation with stereo EEG, which allows us to sample a lot of different areas bilaterally without doing big craniotomies, which can be restrictive sometimes. And it's important to note that, you know, VNS is great, but it does limit some things, like you can't get a functional MRI after putting it in. And until recently, like an RNS, you couldn't get an MRI scan. So you have to think about those things. If you're treating a tumor patient, for example, you don't want to put a device in that disallows MRI scan. Okay. So this is the planning form that we invented and has been accepted for publication in JNS Peds. Basically, these are demographics, so they're blocked out, but basically surgeon me, assistant was Mohammed, and then diagnoses, semiology. So this basically, this one form summarizes all the phase 1 data, and then I use it to create different electrodes, and those electrodes have wonky names, but the wonky names are along this naming protocol, and that allows us to communicate effectively between epileptologists and surgeon. And then I send this to Haley and Sarah and Michael and Eugene, usually the night before. This is a list of electrodes, and then I tell them the recording length and the contact number, and then they fill this chart in during surgery. And then in only 21 steps, you too can do stereo EEG. It's that simple. You just follow these instructions. And this is what it looks like. Lateral x-ray of the head shows all these depths. These are bolts. This is an occipitotemporal trajectory, which is pretty cool. And this is surgeon bragging rights, just saying that, you know, we can put electrodes in pretty accurately along our plan. And this is what it looks like. I mean, like a million electrode contacts here that some poor epileptologist has to read. And some even sadder EEG tech has to make sure is getting data appropriately when the child moves even 1 micrometer. So sorry about that, but good job keeping them intact. This is an example of a seizure coming from the posterior schizocephalic cleft here. You can see the degree of activity and the precision with which you can see even within a single electrode, you know, 1 and 2, very low amplitude, 4 and 5, very high amplitude. And of course, those are closer to the gray matter. So really interesting data. Here's another seizure. And these were provided by Haley. So thanks a lot, Haley. When we did the phase 3, which is bedside mapping, the posterior schizocephalic cleft where the seizures were generated from overlied language. And when that happens, you can't take that out. So we did an RNS. But he didn't become symptomatic until it propagated to his left temporal lobe. So we did explant of stereo EEG, left temporal lobectomy, placement of RNS down the schizocephalic cleft. And you can see these in his posterior schizocephalic cleft. This is a cute little square craniotomy that we did. The child was seizure-free until 6 months when he had a single seizure, and then we were able to turn on the device. And since then, I'm not aware of any seizures. Basically, to conclude, epilepsy is dangerous and stigmatizing and also treatable. Patients can refer themselves, or you can refer them on their behalf to our program to be evaluated. Minimal access surgery is what we try to do first. It's low impact. It sometimes requires iterative treatment multiple times, but it is effective, it is safe, and it will hopefully generate a new wave of patients coming to a comprehensive epilepsy program instead of suffering for their whole life. Again, the goal of epilepsy management is no seizures and no side effects. If that can't be obtained with medicines, it should be obtained with surgery. Our epilepsy program is kind of changing. Unfortunately, Dr. Krimmer is probably going to move on in, I think, December. Ty has moved on. Katrina may move on. But anyways, the rest of us are here to stay, and we're growing the program. So if you want to get involved, please contact us. I don't have my email on here, but feel free to email me, jraskin@iuhealth.org. I think I'm done talking. 5 minutes left.
Mhm. Thank you, Dr. Raskin. We actually do have a question from someone, from an attendee. So I'll read it here. It's a little bit longer, so bear with me. It's from Dr. Miller. He says, what is your opinion on trying stereotactic laser ablation for mesial temporal focus, even an MRI negative pediatric patient, maybe prior to open resection at a later time if necessary? He then goes on to say, we sometimes do feel that mesial temporal focus is electrographically suggested by temporal theta as an earlier finding on scalp EEG. The minimally invasive nature and risk profile seem nice, but 20% 1 year seizure freedom efficacy does seem low. Do we pitch both options to families and let them decide in such cases when both laser and resection are approaches in these patients, or do we strongly recommend resection in those cases?
Yeah, that's a sophisticated question. I mean, you saw the data, so 20% is not high. The risks of laser ablation are low but not zero. It's real surgery when we're in there. I think it's reasonable to pitch it to a family. I mean, you tell, you're not a salesperson, but you are representing the data in an honest way, which you say laser ablation is minimal access surgery. You go home the next day in almost all cases. But in your particular demographic, you're at a much lower chance of it actually being successful versus a little bit bigger of a surgery. But the temporal lobectomy, is a very straightforward anatomical surgery. And people do very well. I wouldn't shy away from the open surgery, but I guess to answer your question, I would say, yeah, it's never bad to pitch both options or multiple options to a family. They should have the right to decide. And some families are just absolutely surgery averse and would rather you do 6 laser ablations in separate settings than to do like a big incision or something. And if that's what it takes to bring those people to the table, then I think that's the whole point of the sort of minimally invasive paradigm, is to make things more accessible to families.
Okay, great. Thank you. Lisa, did you have a question, or are there any other questions? Dr. Miller says thumbs up and thank you.
Got it.
Lisa, if you have your question, you can unmute.
Okay. Can you hear me?
Yeah.
Okay, just making sure. So my question is gonna have to be regarding the connectivity or the connectome,
Connectomics.
Yeah. So I'm not, all that familiar with it, but I do find that it's interesting, and I'm curious to know that when the depth electrodes are placed, the gray matter is where the seizures come from, correct? And then the white matter would be that connective area?
Correct.
Okay, so when you're placing the depth electrodes into the white matter, you're not expecting to have a seizure coming from that area, right?
Yeah, you wouldn't see it come from that area, but you might see it propagate along that area. So you might see some amplitude changes as the seizure propagates.
Okay. So that was just my question, to kind of clarify that that there is a difference between where the seizures are located, white matter versus gray matter, and then the depth electrodes go into the white matter. So I'm just kind of trying to wrap my mind around that. I guess that's all.
Yeah, I mean, to better explain it, there's a seizure is a hypersynchrony of neuronal discharge, and all the neurons are on the outside in the gray matter. So they discharge, and then that electricity propagates down the white matter, which is the wires that go away. So you can imagine if you were recording from where this hypersynchrony happens, where the seizure happens, that's going to be pretty high amplitude. And then whatever propagates down, if you like record from down there, you're still going to maybe see a wave, but it might not be quite as high amplitude.
Okay, so then the deeper the electrode goes in, then that would mean that the longer the propagation distance is? Is that how you figure out how deep to go into?
Oh, the recording length? No, well, no. The recording length I do from the inside of the dura to something that makes me stop, like the ventricle or something. Or if it's a tuber, for example, I'll go the length of the tuber. So the recording lengths differ a bit based on what I'm trying to record. So and the maximal recording length of, you know, a depth electrode for Integra, which is a company we use, is 6 centimeters. So 12 contacts, 5 millimeters apart. And so if you want to record more than 6 centimeters, tough. You can't do it. You can, you know, put one very close to the other and sort of, you know, make them overlap a bit. But anyways, that's how we figure that out.
Okay, thank you.
Dr. Raskin, thank you so much. That was a wonderful presentation. Thanks for coming back.
Yeah, you got it. Thanks a lot. I really appreciate it. I hope you guys have a great day.